Thank you. I will thank Zane and thank Steve for the kind introduction. And even though it will be a bit repetitive to say so, I do have to acknowledge Melissa and Spring and Kara and Laura and the tremendous work that the genetic counselors do. So the fact that you're hearing it from everybody is not because we have a chip that they've implanted, but it's because really without them, all of this wouldn't be possible. They really do the lion's share of this. So I was asked to speak about the latest research in Lynch syndrome. I'm actually going to talk about recent research in Lynch syndrome, I would say. And because I've been given a fairly finite amount of time, which is probably good for all of you, I'm actually going to concentrate on colorectal cancer in research in Lynch syndrome. And there is obviously a question and answer period later on, so if there are questions outside of things that are covered today, probably somebody on the panel, or at least the very smart genetic counselors can help with it. So, as a brief introduction, Lynch syndrome is the most common hereditary colorectal cancer syndrome. But even as the most common syndrome, it accounts for probably around 2 to 3% of all colorectal cancers. The lifetime risk, and you can see that number, that comes from a number of papers, of developing this as colon or rectal cancer specifically, as opposed to any cancer or other cancers, is anywhere between 30 and 70%. And a couple of years ago, we looked at the registry here at about 1,000 people to try to get an idea about that. And these numbers come from that in the graph below. So what you can see from this graph, the first is the top is what gene your mutation, your family's mutation is in, and then whether or not you're male or female. And these are all percentages to the age of 70. So your cumulative risk of developing colorectal cancer. And we did some corrections. It's boring statistical stuff, but it's basically to try not to overestimate things. And so if you have an MSH2 or an MLH1 mutation, and you're a male, you probably have a very significant, something in the 70 to 85% chance of developing colorectal cancer in your life, or within the first 7 years of your life. And but only about 2/3 of that chance if you're female. And then if you have an MSH6 mutation or a PMS2 mutation, the same trend of seeing it generally more commonly in males as females is not there. But the risks are significantly smaller, about a half or a quarter of what they were for the other two genes. So just in a general sense, we think, and this work has been mirrored by lots of other people's work, and I'm going to highlight that on the next slide, that men have a greater chance of developing colorectal cancer in their lifetime in the setting of Lynch syndrome as compared to women. Obviously, nobody is specifically talking about endometrial or ovarian cancer, but no man will develop either of those. So this is a good news, but it's not necessarily an overall good news in terms of expectation. And as said, that MLH1 and MSH2 have a higher risk than MSH6 and PMS2. And these are actually more recent data from larger groups that have also very specifically looked to get rid of all the biases that have led us to overestimate things. And the first one comes from a French group and was published a few years ago. And in fact, their numbers are even smaller. And the graph on the right comes from them. So if you're an MLH1 carrier, you have about a 50% lifetime, as well as if you're an MSH2 carrier. If you're an MSH6 carrier, you only have a 20% chance. But they also saw the same thing, that here the top line is men and here the bottom line is women. And as I said, there's about a 2/3 risk of developing colorectal cancer in females as compared to males. Very recently, because PMS2 mutations are quite less common, so to accrue enough families to try to make these estimates. This paper was published just, in fact, a couple of months ago. And again, mirroring our data that TMS2 definitely confers a risk for colorectal cancer, but it is significantly lower than the other genes. So the rest of my talk, I'm going to talk about various aspects of how we treat and manage Lynch-related colorectal cancer. But I think that this slide is actually a key take-home slide in terms of managing the risk of all cancers in Lynch syndrome. And I think what's very important, I mean, I'm preaching to the converted because you're all here tonight. But really what's key to something like this is talking to your family. You're the ones who have been through genetic counseling, you're the ones who have been through genetic testing, you're the ones who can engage your family. And actually more and more it's becoming that we're not even allowed to engage your families, that there are all kinds of privacy legislation in the country, and things can come informally from family members, but when institutionally we reach out to people, there are all kinds of issues that are coming up and coming to the forefront more and more each year. So it's really important that you talk to the people in your family because they're at risk, and you have to explain to them, look, I may not be able to answer everything, but we have genetic counselors who can talk to you. You potentially can be offered genetic testing. You can be offered clinical recommendations. And this kind of information, this is empowering information. This is the stuff that reduces your risk. And this is the stuff that even if you're going to ultimately get cancer, it's going to make it far more likely that that's a cancer that you're going to survive as opposed to a cancer that will be lethal. So one of the things that's been talked about really, for decades is the fact that it seems to be that in Lynch syndrome, colorectal cancers develop faster than if you look at sporadic colon cancer. And while that is a commonly held belief, because I think most, if not all of us, agree that it's true, there's actually one paper in the literature that actually addresses this subject in a more or less direct fashion, and even this paper isn't a terrific paper, and it was just published a couple of years ago. So the dwell time is defined as what's the time from having normal tissue to having a cancer. So it spans having a polyp, or sometimes in Lynch those are flatter polyps, so that's part of the problem. But essentially, it's this, going from nothing to a cancer. And in this paper that was published a couple of years ago, I won't go through the math, but whether they looked at advanced polyps, so advanced adenomas, or cancers, essentially they came up with this 3-year span. And to compare that, so to go from nothing to cancer or nothing to an advanced polyp in 3 years, is very rapid compared to sporadic colon cancer. So again, there's not fantastic literature in a direct way about it, but in sporadic colon cancer, but it's thought to be about 10 to 15 years in sporadic colon cancer. But indirectly, we know that that's true because colonoscopy, even every 5 or 10 years, significantly reduces the rate of sporadic colon cancer. So we know that it cannot be developing nearly as quickly because it wouldn't make sense that you could screen for it so infrequently, yet effectively reduce the risk. So now the direct things about what we can do in terms of either preventing colon cancer or addressing the colon cancer. So number one on the list is colonoscopy, and virtually every clinical guideline that's out there now, whether it's European, North American, Canadian, American, and there's about a half a dozen different clinical guidelines from very recognized groups, will recommend colonoscopy every 1 to 2 years in Lynch syndrome carriers, or if your family doesn't know what gene, there's been no gene demonstrated, but you clearly have a Lynch syndrome type family, the same thing would hold. And in terms of the graphs on the left show that this type of strategy reduces, first of all, the number of colon cancers. So the people who are having colonoscopies are less likely to develop colon cancer. The other thing is cancer is always better in earlier stages than it is in later stages. So even when we develop a colon cancer, by and large, it's going to be of lower stage, and that's shown in the table below. And it also, in the bottom graph, it decreases mortality from cancer. So the three important endpoints: getting cancer, the stage of the cancer, and whether or not you die from colon cancer are all reduced by screening colonoscopies. And just as a little message, screening means no symptoms. Screening means, you're just there. So, saying, oh, I feel fine and I did it last year or I did it 2 years ago, that's screening colonoscopy. So that's not the reason to not go to your appointment. That's the reason to go to your appointment. But I do want to point out that colonoscopy, while it is considered the gold standard, it isn't perfect. And I can tell you in my clinical practice, and anyone who does this for a living can tell you, we see lots of cancers in people who have had colonoscopies. And in fact, there was a paper published in the province that I haven't summarized here, not to do with Lynch syndrome, to deal with colon cancer in general. And about 3% of people who develop colon cancer in the province of Ontario had a colonoscopy within the last 5 years. And on the right side of the colon, which is actually where the predominance of Lynch syndrome colon cancers occur, in fact, 6% of the provincial cancers that develop had a colonoscopy within 5 years of their colon cancer. So it isn't perfect, but it is the gold standard. So the take-home message is we overdo it. That's why we every 1 to 2 years, but there's a reason it's not perfect. And the second part of that is don't ignore symptoms. So, you had a colonoscopy last year, but you're having, some pretty unusual symptoms in terms of bleeding, weight loss, change of bowel habit. I think everybody in this room knows the types of things that I'm alluding to. Don't ignore those things and get them checked out. So, is there anything else besides colonoscopy that you can do? When I spoke 2 years ago, I spoke about CAP2, which was a cancer prevention trial that was specifically done with individuals with Lynch syndrome. And essentially what it showed is that if you took 600 milligrams of aspirin daily, and this was what's called a randomized controlled trial, placebo controlled, so people were either on a sugar pill or on aspirin. What they found was in the first 2 years there was no difference in terms of whether or not you developed colon cancer. Equally, what they found is that when they took all subjects, there was no difference in developing colon cancer. So effectively, by their primary endpoint, and when studies are set up as prospective studies, that's a really important thing. By the primary endpoint, it was what's called a negative study. It did not show that there was a difference in developing colon cancer. However, they did do an analysis of looking at just the people who were compliant with taking aspirin for at least 2 years. So in other words, just because they randomized you to aspirin didn't mean that you necessarily took the aspirin on a regular basis. But what they did is, when they just concentrated on the people who either took their sugar pill regularly for 2 years or took their aspirin regularly for 2 years, was that after 2 years, you started seeing a significant difference in the likelihood of developing colon cancer. And I haven't shown it here because my talk today is about colon cancer, but other Lynch-related cancers as well. So that was published in The Lancet a few years ago. It's been sort of interesting because it's definitely a positive trial in terms of that outcome and what they showed. However, it is one trial. And it also is a high dose of aspirin. Again, for the people in the room who maybe take aspirin for their heart or for other reasons, generally that's 81 milligrams. This is 600 milligrams. And while in this particular study there was no difference in the likelihood of something bad happening to you when you're on aspirin versus a sugar pill. People all the clinical guideline bodies have been slow to sort of make any really strong statements about this. So generally speaking, most of them say aspirin may be considered. So I would say your take-home message should be, talk to your family doctor. If there isn't a reason not to be on aspirin, then probably being on baby dose aspirin is not a bad starting point. It's very hard for me to stand here in front of you and say, go home and take 600 milligrams a day, because as I say, that is a very high dose of aspirin, and it can be associated with problems with your kidneys, with bleeding problems, things like that. Now, interestingly, and I'm going to take a little straw poll in a second, there is a study that has just started in Europe in terms of accruing patients, and we potentially are interested in joining it, which effectively is looking at whether or not you have to be on that much aspirin. So it's CAP-free, very specific to individuals with Lynch syndrome, looking at people who would be willing to be randomized to one of 3 doses. You wouldn't know what dose it is, but it's one of those 3 doses. There's no sugar pill in this particular study, so everybody is receiving treatment. And they, the expectation would be that they would be on it for at least 2 years for the study. And so that study is just starting, and we actually have some interest in potentially joining that study. So the one thing I'm going to ask is, as a straw poll, and if you're too shy to put up your hand, that's fine. But those who have a little bit of courage, if there are people in the room, and I suspect there's a couple in here who have Lynch syndrome, if you would be interested and willing to join a trial where you would be expected to be randomized to aspirin. Okay. We have some.
2 years?
Yes, 2 years. Yeah.
So you can already be on some aspirin for the start.
Sorry?
So you can already be taking baby aspirin for the start.
Yes. Okay. So I'm going to talk about a few other topics within colon cancer, and I'll be done in a couple of minutes here. So this long word to talk here of Metacrinus, that really means developing another colon cancer after you've had colon cancer. So you can have one colon cancer, you can have 2 colon cancers at the same time, that's called synchronous, or you can have colon cancer after colon cancer, that's called metacrinous. So I've been interested in the risk of, I'm interested in quite a few things, but I was interested in the risk of what are the risks in terms of developing another colon cancer after you've had colon cancer, because where I'm going to come to in one slide from now is, well, is there anything we can do about that? And in fact, there is a little bit of literature that's already out there and pretty good, also within the last few years. Both the 2 papers come from the Colon Family Registries, which Steve has contributed a lot to. And the first one looks at what's the risk of developing colon cancer after colon cancer in Lynch syndrome. And what you can see here is that this goes up over time. These are what are called confidence intervals, and the middle line is it. So essentially, 10 years after you've had colon cancer and you have Lynch syndrome, there was 16% of developing another colon cancer. And this is the real world. So most of these people are actually having colonoscopies. Not everybody, it's the real world, but most of them. And equally, when we say the real world, some of them may be having it once every year, some of them may be having it once every 5 years. Like it's not controlled for. 20 years after, the likelihood is up to 60 years in this analysis. Really interesting are people also who see very similar numbers. So if you have an operation for rectal cancer, what is your likelihood of developing a colon cancer after you've had your rectum resected for rectal cancer? And very similar numbers, about 19% at 10 years and about 50% at 20 years. And more recently, we looked at the registry patients, and we were trying to answer a slightly different question. So we just looked at all individuals who were very young when they were diagnosed with colon cancer, who did not have what's called polyposis. So they all looked like Lynch syndrome, at least not in terms of their family history, but looked like Lynch syndrome in terms of they just showed up with colon cancer at a very young age. And the two graphs here show the individuals with Lynch syndrome and those who didn't have Lynch syndrome. And essentially what you can see is almost identical numbers. So those with Lynch syndrome had a 16% chance of developing another colon cancer in 10 years, and about a 60% chance of developing another colon cancer if you looked at 20 years from their first cancer. And then the other thing in our study is that was very significantly different than other young people who just ended up with colon cancer. So it was far more likely if you had Lynch syndrome and had colon cancer that you would develop another colon cancer as compared to if you didn't have Lynch syndrome but developed colon cancer at a young age. So in terms of practice guidelines, most practice guidelines say consider extended resection for individuals with Lynch syndrome undergoing colorectal resection. So this is a bit of a wishy-washy statement as well. I'm going to get into it a little bit in the next couple of slides, and it's because there is decent data, but not great data about this. But I think, and this is important, the extent of resection has to be balanced with the morbidity of surgery, that is the likelihood of developing a complication or recovery and all those things. Also the quality of life issues, so the more colon we remove, the more variable your bowel habits are going to be. And also that there are alternative risk-reducing measures. In other words, if you're going to go for your colonoscopy every year, do you really need to have more colon taken out to reduce your risk? So what are we talking about? Well, for colon cancer, these are the standard resections. So if you have a cancer in the right colon, we remove the right colon and you look like this. If you have a colon in the left colon, we remove the left colon and you look like this something. Later, if you have in your sigmoid colon, we remove the sigmoid colon and it looks something like this. But instead of that, essentially, you could have your cancer in any of those positions, but we remove essentially your whole colon. We leave your rectum. Sometimes we leave a little bit of the sigmoid colon here as well. And we hook you up the small bowel to the rectum. And that's what we're talking about with an extended resection. And I do have a slide about the quality of life stuff about that for people who are wondering, well, that doesn't sound too good in terms of what actually happens to your bowel. First, I'll talk about the risk of cancer. So essentially, this is the literature. This is it. So in terms of whether or not that type of approach works. So the largest study, again, also came out of the colon family registry, looking at about 330 patients. And if you had a standard operation, you had about a 16% chance of developing another colon cancer follow-up versus an extended resection where it was 0. This is over 10 years. In ours, it was about 16% and about 7%. In other studies, the numbers are higher, but they all show the same trend, that if you have a portion of your colon, like the standard cancer operation, you have a higher risk than if we take out more of your colon, which kind of makes intuitive sense of what happens. So extended resection reduces the risk of metachronous colorectal cancer in Lynch syndrome. But if you look, metachronous colon cancers, these cancers after cancer, are somewhere between 0 and 15% after extended resection. So I think that says something, because again, these are real world. These are people who are being scoped. So I think it says, first of all, you have to get scoped. So you can't just have your extended resection and then think it's all over. You still have to have follow-up. Usually it's sigmoidoscopy at that point. You're not dealing with your colon. It's a smaller procedure. But it's still required. And again, like colonoscopy, it's not perfect. You can still develop cancer. Sometimes we aren't able to remove the polyps before that. I think that this is my last data slide before summarizing. So I did want to, there is exactly one paper talking about the quality of life Not after extended resection, there are papers like that, but specifically in Lynch syndrome, in Lynch patients, and this is a relatively recent paper that was published looking at Dutch Lynch syndrome patients and looking at 3 different ways of looking at quality of life. So one was a very generic quality of life measure, and they found no difference in any of the measures, and you can see what they are here, like general health, vitality, emotional, mental, social functioning, pain, physical roles, and physical functioning. This is a quality of life questionnaire that addresses colorectal cancer, specifically by a European cancer group. And if you had an extended resection, if you had the bigger, you were statistically more likely to have worse issues in terms of defecation. Interestingly, and sort of shows you, again, when we do these types of studies, there's no reason I can give you for this. Actually, the individuals who had the standard resection, as opposed to the extended resection, there was a statistically higher likelihood of having male sexual dysfunction in that group. It's there, so I report it, but it doesn't. It's not something we can really make sense of. And then there's no difference in, as you see, these were measured as differences in things specifically related to colorectal cancer management, but virtually everything else was the same in terms of quality of life. And then, more general colorectal surgery as opposed to colorectal cancer quality of life questionnaire. Extended resection had 3 different metrics that were worse in the extended resection groups. So stool frequency, so the number of bowel movements each day. Social impact in terms of, overall from the surgery, but presumably related to their bowel habits, and stool-related aspects. That's but again, no difference in actually the total score in terms of your quality of life in this, need for medication or incontinence. So, I apologize, there was one response. So Lynch syndrome and chemotherapy, and I'm going to, even though there's a lot on here, it's an extremely controversial topic. Essentially, many of you may know, but there is chemotherapy that's generally recommended for people with stage 3 colon cancer and select cases of people with stage 2 colon cancers. And the reason for that is that it works. But most studies looking at this in people primarily who have not necessarily Lynch syndrome cancer, but cancers that look like Lynch syndrome. And I could explain that in more detail if anyone wants to know later, but instead of looking at 2 or 3% of the population, we're looking at about 15% of the population. They don't appear to benefit from 5-30 or so based chemotherapy, which is the standard of care. In distinction to those people who don't have cancers that look like that, who clearly do benefit, and that's why we use that type of chemotherapy. But it's a very controversial topic, and I would say to date, first of all, none of the consensus bodies will even weigh in on this at all. They just leave it out. And most people's feelings are, if you have stage 3 colon cancer, have standard adjuvant chemo. So Lynch syndrome, not Lynch syndrome, you should have it. That we don't have enough reason to avoid it. But in stage 2, where it's selective, you probably don't need it. And the one thing I didn't touch on this is, in Lynch syndrome, this is good news for people in this audience, your prognosis is better. So if you have stage 2 colon cancer, sporadic stage 2 colon cancer, Lynch, you looked at 100 people in each group, you would have more survivors in the Lynch group than you would in the sporadic. So there's something intrinsic about the Lynch cancers that they behave better in terms of their prognosis long term. So this is just a summary saying men more likely than women to develop colon cancer and the genes, if there's an accelerated progression, improved survival. That screening colonoscopy is important because it decreases the likelihood of developing cancer, the cancer stage, and the mortality, but it does not prevent all cancer. Aspirin is on the horizon for this. There's decent evidence, and we're working on it more. And that there is an increased risk of developing another colon cancer after your colon cancer. So because of that, you should think about having an extended resection. We know that that reduces the risk, but it also does have some quality of life consequences. And that even after that, you need screening colonoscopy or sigmoidoscopy. And actually, chemotherapy continues to be recommended in stage 3 Lynch syndrome, but generally is not indicated in stage 2. And as I started off by saying, talk to your family, discuss your genetic testing results, and encourage them to speak with a genetic counselor. Thank you.